First of all, thanks to my invitation to this conference. My group today will be short about treatment of dyslipidemia within limited resources. First of all, we know that cardiovascular risk is a global cause of this, one of the most common causes of this all over the world. And it is a challenge of cardiovascular risk all over. Egypt, one of the most very red zone over the map, and very high risk for cardiovascular disease. All the north of Africa are very high risk to cardiovascular disease. Dyslipidemia is a serial killer that's always underestimated when population reach their first event. احنا دايما مش بنحس بخطورة الديسليبيديميا إلا مع أول attack. And with the first acute scale attack, we consider dyslipidemia. When the dangerous is starting very early term. When the abnormal level is the major risk factor, account about 50% of the major risk factor leading to acute coronary syndrome and cardiovascular risk. When using the LDL 21 risk reduction of major vascular disease will decrease the vascular risk and all major vascular events. So the relation between the cardiovascular event and the LDL is a linear relation. The more the LDL we have, the more risk we have for cardiovascular, and also the more reduction in LDL, the more protection we have in cardiovascular disease. According the guidelines of preventive guidelines in 2021 about the preventive cardiology, we starting dividing the population into 5 groups. First group, the population will have accelerated vascular disease, either by clinically have the TIA, myocardial infarction, acute coronary syndrome, peripheral arterial disease, stroke, or by imaging when we have an stenosis more than 50% in one or more of the coronary or aortic or carotid vessels. So this is accelerated vascular disease. Second group, atherosclerosis diabetes mellitus. Third, CKD. And fourth is familial hypercholesterolemia. And finally, the patient out the person who not have the all of the above, we consider him apparently healthy. Not really healthy, but apparently healthy. So, when we talk first about accelerated vascular disease, all of this group are very high risk. All of this group are very high risk. When we talk about diabetes mellitus, when we have diabetes without target organ damage and less than 10 years duration, it's a moderate risk. When we have more than 10 years of duration and without target organ damage, it is a high risk. When we have a target organ damage, of course, it is a very high risk, or we have more than 20 years duration or associated with CKD. This is diabetes mellitus. Finally, the CKD, we have only high and very high. There is no CKD patient, is a moderate risk. All CKD patients either high or very high risk for cardiovascular disease. And finally, familial hypercholesterolemia, all of the patients are high risk for cardiovascular disease. The first group was called apparently healthy. That the people who don't have diabetes, don't have CKD, don't have dyslipidemia, don't have accelerated disease, is considered as apparently healthy people. We score this people according to score 2, score, and score up when we either according to blood pressure, according to non-HDL cholesterol, according to age, according to sex, according to smoker or non-smoker. We can easily use a mobile app, cardiovascular Android or iOS. You can train my patient or our patient cardiovascular risk to have this app and we score for the patient, and we choose the country. Egypt is a very high risk country and very high risk region. We start to calculate. When we look at this score, that we found a very difficult fact, and that is all the Egyptian people above 55 years old are very high risk. It is a very risk fact. So all of us mostly are very high risk, and all the females are smokers are very high risk, and all men smokers in Egypt are very high risk. So the magnitude of the problem is very high, must face it. So as regarding this dyslipidemia. We have a different target according to guidelines of 1912. According to the risk, when we hire patients with very high risk, we must reduce the LDL to 55 milligram per deciliter. When we high, we must use 70, moderate, reach 100. This is the target we have according to risk. We calculate the risk. It's a very high, must reach 55, high 70, moderate to reach 100. What is the tools we have to reach this target? We must know our tools and the magnitude of the tools. The power of this tool. We have moderate intensity statin, that is ELTOHFA 10, ELTOHFA 20, DYSLIPIDEMIA 10, and circumstance. And in high intensity statin, DYSLIPIDEMIA 20 and 40, and ELTOHFA 40 and 80, we have high intensity statin plus dopamine and PCSK9 inhibitor and PCSK9 plus intensity statin and all of the above. So, the other part is the reduction, the percentage of reduction we have. When we use a high intensity statin, we have 30%. When we have high intensity statin, we have 65%. So, when we have a patient with a baseline LDL and we want to reach the target, we calculate what's the edge formula can reach the target. I need 50%, 30%, 70%. I need 50%, so high intensity statin is enough. So if I need 60% reduction, so I will go for high intensity statin plus escitalopram. But I need more than, I need 7, I need 8. According to the percentage I need to reach my target, I can use from the start my weapon according to its power. So we can misuse our tools. We cannot use a tool which is very high, expensive, like PCSK9, while we can use tools otherwise like high intensity statin plus escitalopram to reach our target. Also, a new weapon we can use what's called the nucleic acid. Nucleic acid. A new weapon we can use in this patient, we add a more 80% reduction to non-familiar hypercholesterolemia and 20% more addition, more to 80 to 20 addition percent in that patient. This can be a more dose, a further step I can use high intensity statin and escitalopram before I go for PCSK9. So, if I have a patient, I go for statin therapy. If the statin is tolerant, I can use nucleic acid. If I reach the goal with the statin, if I don't reach the goal, I add escitalopram. Still, not reach the goal, I can add in nucleic acid before I reach to PCSK9. And this also again is a percentage I can have with the combination of drugs with additional nucleic acid. As we say, I can reach 50% reduction. High statin, high statin, nucleic acid, 70%. And high intensity statin with nucleic acid, I can reach 75% reduction. So, at this stage, I can use necessary weapons of this affordable price before I can advance the level of drugs like PCSK9 with 85. I said most observation we get enough 75% reduction to reach our goal. This strategy is international expert. When I have a baseline level 100, this is a currency group. Baseline 100 to 160. And as a currency group, I go for high intensity statin and escitalopram combination from the first. If I don't reach the target, I add the nucleic acid. If I don't reach the target, I will add finally PCSK9 inhibitor. And if my baseline is less than 160, I go for that level high intensity statin and nucleic acid escitalopram from the start. So you can do that. You have more than tools to treat with dyslipidemia. That serial killer, that very risky for cardiovascular disease. I have further steps with affordable price to treat the high intensity statin, escitalopram, and finally, if I don't reach, I will go for PCSK9. Thank you.